First off, I want to recognize my colleague and executive director, Dr. Kate Smith, has joined us this evening, and she'll be assisting as a co-host. Welcome to Spring 2024 North Delaware Mini Medical School. We do this in collaboration with Christiana Care. And here are the URLs for the Delaware Mini Med program and for Christiana Care. Follow us on social media. We'd love to have more followers. We're on LinkedIn, we're on Instagram, Facebook, and yes, even on Twitter. About the program briefly, the Academy was founded in 1930. Mini-Med has been running continuously since 2009. These semesters are offered as a part of the Delaware Health Force initiative of this organization, which is supported by state and local fiscal recovery funds through the Department of Treasury and the state of Delaware. There are no tests or grades. Yay. This series that you're in right now is one of at least three series that will occur between now and the end of the year. Interested students can attend additional series as they are announced. And in fact, we encourage you to do that. Stay tuned at DelawareMiniMed.org for future dates and times. For those of you who are adult learners and perhaps are already in medicine, there is no continuing medical education or continuing education credits. This is not an accredited training. If you're here for your own edification, that's great. Participants to all 6 sessions live will receive a certificate of achievement. And as I mentioned last week, if you miss a session, we now allow that you can make it up by watching the recording, then emailing tgibbs@delamed.org, that's me, and I will send you a question or two to answer. They'll be simple, but we do need proof that you watched the presentation. Program goals: we want to enhance health literacy in our community. We want to expose middle, junior, high school, undergrad, grad students to a range of topics and types of providers as a part of career goal setting. Those providers that we have, our instructors are going to share career pathways to clarify how they got to where they are today instructing you. And we also want to encourage a dialogue between you, the audience, and the instructors in a safe setting where your medical issues aren't in question. You're not about to get a shot. You're not about to get a filling. But along those lines, please don't ask any personal health questions. And that's one of the housekeeping tips here, which is, don't ask questions of a personal or family nature. This is a Zoom webinar. You can't see each other, and you can turn your cameras off. We can't see you either, only your name. There are over 1,000 students registered for the series. Therefore, getting to everyone's questions is just about impossible, but we will try. And along those lines, please look in the Q&A and see whether the question that you're about to ask has already been asked by someone else. For students who are going for your certificate, you do need to stay through the entire presentation. And yes, we can see when you log in and when you log out. When the presentation is officially over and we go to Q&A, you can leave. But I will tell you, honestly, that's when a lot of the good conversation occurs. I already told you to turn your webcam off. You can go to YouTube. I've already been getting emails. Unfortunately, there's not a direct way to ask questions through YouTube. Sorry about that. Maybe we'll figure that out in the next series. If you used your link to log in this evening, we know that you've logged in. You don't need to independently email us. However, if you want to, send an email to tgibbs@delamed.org just to make sure. The Youth Medical Academy, you can read more about at DelawareMiniMed.org. I'm not going to review the nuances of this again. This evening, we are joined by Dr. Brian Nam. He's going to be talking about thoracic surgery and robotic surgery. After graduating from Northwestern University with a bachelor's degree in chemistry, Brian Nam, MD, earned his medical degree from the University of Minnesota. He then moved to the Mayo Clinic in Rochester, Minnesota to complete his residency in general surgery, finishing as chief resident. Dr. Nam was a cardiothoracic surgeon fellow and a thoracic surgeon at the University of Wisconsin before joining the Helen F. Graham Cancer Center at ChristianaCare in 2012. Dr. Nam is a clinical assistant professor of surgery at Thomas Jefferson University and a clinical member of the Wistar Institute in Philadelphia. He has collaborated on a number of research projects, including the development of blood markers for lung cancer. He has presented research to the Society of Thoracic Surgery on the impact of the universal bed on decreasing hospital length of stay. His publications include the utility of robotic surgery in the American College of Surgery. He is also actively involved in lung cancer clinical trials at the Helen F. Graham Cancer Center. Outside of medicine, Dr. Nam has a significant teaching experience and is involved in the general surgery residency program at ChristianaCare. He is fluent in English and proficient in Korean and Spanish. This evening, Dr. Nam will be talking about, as I said, the lung cancer and advances in treatment, robotic surgery. And at this point, I will stop screen sharing and I will turn it over to Dr. Nam. Doctor, over to you.
All righty. Thank you so much, Mr. Gibbs, for allowing me to speak to all of you today. To be honest, it wasn't so long ago when I was actually in the viewer's shoes and watching, videos of doctors talking about, what they do and thinking about becoming a doctor one day. But let me get started with my slides here. Is that coming up okay, Tim? Does that look okay?
Not seeing them yet.
Okay, second.
Seeing, there you go. Thank you.
Okay. Okay, great. So today's talk, I'm going to give an overview of lung cancer and some of the exciting new treatments that have come along, especially in the past, recent past 15 years or so. There's been a lot of exciting advancements that have happened in the field of lung cancer. So for today's talk, I'm going to be talking about cancer statistics, the diagnosis and staging of lung cancer, the new treatment options that have come about in the past 10, 15 years, and some of the new technological advances, that have, made treatment much better for patients. So this is a pretty common slide that we see in med school a lot. Basically, lung cancer is the #1 cause of cancer-related death in the United States. This first bar graph right here illustrates the most common cancers that are diagnosed every year in the United States. Breast cancer is most common, then followed by prostate cancer, and then and lung cancer is actually the third most common cancer diagnosed. However, because it is diagnosed so late in its course, and because it's a really an aggressive, type of cancer, the death from lung cancer is #1 by a wide margin. And so we need to try to improve that. So unfortunately, for a long time, survival rates for lung cancer really haven't changed for almost 30 years. So in this first bar graph right here, while there were significant improvements like breast cancer, the survival rates got better. Prostate cancer, they got better by a lot. Colon cancer got better, but lung cancer we didn't really make a lot of headway in terms of making a dent in lung cancer for a long time. However, in the past 15 years ago, because of some of the newer medications that have come out, some of the newer things that we're doing, we have been able to make at least a gradual improvement, and hopefully in the next few years, this will really start to take off. So that's exciting. So I like this graph because this is, it really kind of illustrates why people get lung cancer. So smoking cigarettes is responsible for 80 to 90% of all lung cancers that are diagnosed. So this blue line right here shows, how prevalent smoking was in the United States across time. So smoking peaked in the U.S. In the 1960s, where about 50% of the entire population was smoking. The good news is that has gradually declined over time to where right now only about 15% of the U.S. population smokes. But you can see, I mean, this red line and green line here. So this red line is lung cancer related deaths in men, and the green line is lung cancer related deaths in women. And you can see how closely these lines mirror the smoking prevalence. But non-smokers do also get lung cancer. The most common other reasons for developing lung cancer include radon exposure, secondhand smoking, and then a family history or genetics. So how do we diagnose lung cancer? There's two types of imaging tests that we use most often. One is a simple chest X-ray. You can kind of see here in this patient, they're facing us. In the top part of in their right lung, you can kind of see a kind of a white sort of spot. And so a chest X-ray is a simple tool. But most often we get a CAT scan. So a CAT scan gives us kind of more information. It can pick up smaller spots in the lungs. And this arrow is kind of pointing to kind of a suspicious looking spot in the lung. Another test that we use to try to identify cancer is something called a PET scan, a PET scan. So this is like a full body scan, and cancer, if it's present, will light up, kind of like it'll look really bright and yellow, and it helps us diagnose cancer throughout the body. Once we identify, concerning spots for cancer on an imaging test, we have to confirm that these spots are actually cancerous. And this is a relatively new tool that came out a few years ago, and that we're fortunate to have at Christiana, something called a robotic bronchoscope. Let me bring this over right here. So robotics, has come into play in the medical field and has really advanced some of the tools that we use, to diagnose and to treat lung cancer. So this is a robotic bronchoscope. It has two arms that control a small scope that we direct into the lungs. Okay, so it's kind of a cool sort of thing right there. And then we use this, it's basically like a PlayStation or a game controller sort of device, and we manipulate or drive that scope deep into the lungs. And there's a computer program that takes the patient's CAT scan and turns it into basically a roadmap. And just like a video game, we can make our way into the edges of the lung where these spots show up on the CAT scan, and then we can take really accurate biopsies. And there's actually there's a camera on the tip of the scope, and you can actually, it's a little blurry, but this red spot right here is actually the cancer in the lung, way on the edge of the lung. And you can actually watch the needle, take several biopsies of the cancer. So this is really an advanced sort of tool that we just developed and have access to. It's really been quite helpful. And in the future, what we hope to do is to be able to actually treat small lung cancers with this fancy robotic bronchoscope. We're not quite there yet, but at some point that'll be a reality. Okay, so after we make a diagnosis of lung cancer, we have to stage patients. This is kind of a busy slide. I don't expect you guys to look at it really closely. But when we're talking about stages of cancer, there's usually 4 common stages of cancer, 1 to 4. And for most types of cancer, it depends on the size of the cancer, whether or not there's lymph node involvement, whether or not there's a metastasis, which means that the cancer has spread to somewhere else in the body. And then, so you take all these three sort of factors, you kind of plug them into this, chart here, and it'll tell you exactly which stage of cancer the patient has. In general, this is kind of a very concise sort of abbreviated categorization of the stages. But for stage 1 lung cancers, we're talking about cancers that are relatively small and small size. So cancers that are under usually 3 or 4 centimeters in size. For stage 2 cancers, we're talking about cancers that have spread to lymph nodes that are right next to your lung. Lymph nodes are part of your immune system. You have them throughout your body. But they help fight off infections, but they can be kind of the first places that cancer can spread to. When we're talking about stage 3 lung cancer, we're talking about cancers that have spread to kind of more distant lymph nodes in the chest, kind of in the middle part of the chest or sometimes on the other side. And then when we're talking about stage 4 cancer, these are cancers that have spread outside of the lung to either like the liver or to the brain, somewhere else in the body. So treatment options have really advanced over the past few years. Surgery, we used to have to make a big incision, spread the ribs to cut out, cancers in the lung. Fortunately, we don't have to do that these days, so the recovery time is a lot faster. Patients just do a lot better overall. Radiation has also come a long way in terms of we can really give focused radiation to get rid of small spots of cancer in the lungs. Chemotherapy has been around for a long time. Chemotherapy works, but there are side effects. And some of the new advances, which I'll talk about later, include newer drugs that have come out, on the market that have really improved that, survival curve for lung cancer. And I'm going to talk about targeted drugs and something called immunotherapy, which you have maybe seen commercials or ads, talking about these newer medications. So, there's an old approach in terms of how we treated, lung cancer for each stage, but there's a modern approach where we've been able to integrate some of these newer sort of things to really, improve survival for each of these stages. So for stage 1, usually, we can usually treat these patients with, these are small lung cancers. We can usually just do surgery and cut them out. But now we can do surgery robotically with a camera, little instruments. And then if we can't do surgery, then we can do what's called stereotactic radiation, a very focused radiation, and basically get rid of cancers that way. For stage 2 lung cancer, once again, these are cancers that have spread locally to some of the lymph nodes around the lung. Usually, in the old days, we did surgery and then chemotherapy, but now we can do robotics, chemotherapy, and then targeted medications. That's really helped survival. For stage 3 cancers, once again, these are cancers that have spread to lymph nodes a little bit farther away from the lung. We usually didn't do surgery. We usually treated these with chemotherapy and radiation therapy. But now, since these medications are better, we can add robotic surgery, and we can also add something called immunotherapy, to the treatment regimen. And then for stage 4 lung cancer, we didn't have a lot of options. We just had chemotherapy, but now we have targeted therapy and immunotherapy as well. And this has really helped patients out. So for stage 1 lung cancer, once again, these are small lung cancers. Nowadays we use robotic surgery to cut out lung cancers, and then that stereotactic radiation therapy. This is called cyberknife therapy. So basically, what that entails is they can give a very high dose of radiation to where the cancer is, while not giving a lot of radiation to the surrounding structures in the body. So people tolerate it relatively well. There's not a lot of side effects, and it does a pretty good job of getting rid of small lung cancers. Once again, for stage 2 lung cancers, we've added robotic surgery and targeted therapy to their treatment paradigms. And so targeted therapy are medications that target certain types of genetic changes on the patient's individual cancer. And as a result, these medications can be much more effective than traditional chemotherapy because they're targeting just the cancer cells and not the other cells in the body. These medications tend to be given orally, so that's a lot easier than chemotherapy drugs, which are oftentimes given intravenously. and there's a lot less side effects as well. So just to kind of step back for a second, what are we talking about when we're talking about chemotherapy? So chemotherapy are usually IV medications or intravenous medications. They do work, but they work by destroying rapidly growing cells. So these are parts of the body. Cancer is basically cells that are growing rapidly and abnormally and spreading to other parts of the body. And these medications kill these cells because they're growing so quickly, but they're not targeted just to cancer cells. So they will target other parts of the body that are dividing. So all cells are naturally dividing everywhere. So as a result, there's more side effects, and hair thinning, nausea. There's a lot of potential side effects with chemotherapy. So when we're talking about targeted therapy, like I said, so cancer cells have certain sorts of genetic alterations or targets on the surface of the cell. And these medications can target these certain genetic changes very specifically without actually affecting other parts of the body. So once again, they can be very effective because they're targeting cancer cells that you have without destroying other parts of the body. These medications have come out just in the past 20 years. And this is a list of basically some of the targets that these medications, go after. And this list basically, increases every year. I mean, it's exponential in terms of the number of new medications that we can offer to patients. For stage 3 lung cancer, in the past, we couldn't do surgery. But with now something called immunotherapy, we can shrink cancers where surgery is now, feasible. And so immunotherapy is a new type of, medication that works differently than chemotherapy or even targeted therapy. These are medications that boost your immune system to target cancer. So in this picture here, it's a little complicated, but if this blue guy is an immune cell and this pink guy is a cancer cell, immunotherapy is basically this helmet, and it prevents the cancer cell from basically attaching to the immune cell and hiding itself by attaching to the immune cell. And as a result, because the cancer cell can't attach to the immune cell, your normal immune system can identify the cancer cells and destroy them. So these are intravenous medications, but they can have less side effects than traditional chemotherapy and can be very effective. So this has been very helpful for our patients. And then for stage 4 cancer, in the past we just had chemotherapy, but now we have targeted therapy and the immune therapy. So as I've just mentioned, lung cancer treatment is pretty complex. There's a lot of different sort of things that we can offer patients. These everyone has kind of their expert sort of realm. So we developed what's called a multidisciplinary clinic here at the Helen Graham Cancer Center, and basically patients can come and see not only myself as a surgeon, but they can see a medical oncologist and a radiation oncologist all at the same time, and that way you can get a synthesized sort of efficient plan that may incorporate surgery, chemotherapy, and radiation therapy. And you don't have to see all of us at different times and over the course of weeks. So it can really help speed up the process for treating patients with cancer. Also, there's a number of other specialists that patients will see when they come to see us. There's social workers, geneticists, nutritionists, psychologists, palliative care specialists. They're all part of the cancer team, and they're all here to help patients on this journey. So, this is a time cover from, I think this is 2013, 2012. How do we cure cancer? I mean, this is, this goal has been around for quite some time, and for the most part, for lung cancer, we haven't been able to do it, but we're making progress. As I mentioned earlier in the presentation, the 5-year survival rate for lung cancer is much worse than it is for other cancers. And this is oftentimes because we find the cancer too late when patients have stage 4 lung cancer, and the prognosis is just not great when we find it at higher stages. So this pie chart kind of shows, I mean, once again, more than half the patients that we find that we diagnose with lung cancer, unfortunately, are diagnosed at the latest stage. And as you can see in this bar graph, the survival, if we can catch it early enough, we can cure most patients. But if we, in that 50% that we identify too late, the prognosis is just not as good. So we have to try to find these patients earlier. So, how do we cure cancer? There's a few time points, that we can try to, reduce the incidence of lung cancer. The most obvious one is prevention, which means, smoking cessation. And to be honest, I mean, we're doing a pretty good job of doing that. I mean, smoking rates have gone down from 50% nationwide to just 15% most recently. The other option, if we catch it too late, is to develop new drugs to help patients who have advanced lung cancer. And we are doing that as well. And that includes targeted therapy, medications, and then the immune therapy, which we talked about before. But a lot of research right now is being done on trying to diagnose these patients, when they have earlier stages, so early diagnosis. And we do that with lung cancer screening, something called biomarkers and something called radiomics. And I'll talk a little bit about that next. So a big thing that came out just 10 years ago is lung cancer screening. The bottom line is that just like, patients get a mammogram for breast cancer or a colonoscopy for colon cancer, everyone with a heavy smoking history should get a low-dose CAT scan on a yearly basis. And this will help, this has shown to reduce the lung cancer-related mortality by about 20%. So this has gone a long way to help us detect lung cancer at an earlier stage when we can do more about it. And we have what's called a lung health program here at Christiana, where patients can get a low-dose CAT scan. And then biomarkers. So a biomarker is a simple test that can identify patients with cancer. And there's all types of biomarkers that exist. A simple one is just kind of the holy grail is developing like a blood test, a simple blood test. Maybe you can get your finger pricked, and then we can analyze the blood and see if there's any, see if that patient has cancer. We still haven't quite done it yet. Part of my research, with the Wistar Institute in Philadelphia, is to try to develop, one of these, some type of biomarker that can do this. But there's a lot of progress being made in trying to develop some type of test like this. Something else that's interesting in terms of artificial intelligence or machine learning. These are obviously big buzzwords that have come out recently. But using computing program or computing power to really help us diagnose small lung cancers, and radiologists are using machine learning to basically help them pick up small spots in the lungs on the CAT scans and to try to determine whether or not that spot is actually cancerous or not. And they kind of use all sorts of CAT scan related features to help determine this. So that's another area of research that people are quite interested in. And then I'm going to talk a little bit about robotics. So, what do we actually mean by robotics? Are we talking about robots doing surgery on patients by themselves? So surprisingly, it's possible that one day we might get to that point. We're not quite there yet. But there was a robot developed at Johns Hopkins University 2 years ago that did a intestinal connection. You can kind of see it in the monitor in the back screen in the back here. But basically, they connected two ends of the intestine in a pig together without the help of any sort of surgeon or technician. But this is still a ways away from becoming a reality for us. When we're talking about robotics, we're talking about a tool or a platform that uses little robotically driven instruments, just like that bronchoscope, but that we can place, into the body that basically become our hands, on the inside of the body. And so, let me just switch to screen here. Yeah. So this is a video of robotic surgery on the lung. The surgeon is controlling these little instruments from a console. He's actually sitting at this platform that sits next to the patient. And the robot has a lot of great features that make surgery just much easier, much more precise. It allows us to do complicated operations. It has a lot of advantages over even, laparoscopic surgery. Being able to use these robotic, instruments, they're just much more precise and more helpful. I always get asked, how do you actually cut out the lung? There is let's see here. There's a stapling device that we use at, there's a robotic stapler that we use. Here it is. That fires a whole bunch of little permanent staples and kind of cuts in between the staples. And that's how we actually, cut out or take out, small pieces of the lung. Okay, so go back to my slide here. So once again, yeah, the surgeon is kind of peering into this, console right here, and he's there's little instruments that he's holding that drive these instruments that are at the patient's bed. So that's what we're talking about with robotic surgery. So it's precision surgery. There's a lot less post-operative pain. Patients, recover a lot faster. The average hospital stay for a lung resection is about 2 days. And overall, it's good in terms of the financial health of our health system. So that's it for my talk. Just the conclusions. There's been a lot of advancements in lung cancer recently. A lot of new medications, targeted drugs, immune therapy. We're improving early detection. There's also been significant technological and robotic advances, and so hopefully we can continue to push this curve upwards, over time. So it was great to talk to everyone. If anyone has any questions that they want to, get a hold of me later on, my email address is here on the bottom.
All righty. Thank you much. There were a lot of questions. So we'll wait for Kate. There we go. Dr. Smith.
Here I am. I was answering a question. Sorry about that. Thank you very much, Dr. Nam. That was fascinating. And there are quite a few questions. So I'm going to go through the questions that were asked towards the beginning of the presentation, and then we'll work our way to the ones that were asked towards the end. So the first question, and we got it kind of several times in several different versions, is, when you're talking about smoking as a risk factor, does it matter if it's not tobacco? So we had questions about marijuana, we had questions about vaping, and we had questions about e-cigarettes. So do you know of anything about those as it pertains to risk factors?
Yeah, so those are great questions, and patients ask me all the time. So in general, we don't know the risks of lung cancer with marijuana, and especially vaping. Vaping has only been around for the past for 10 years or so. And, it takes a while for the effects to build up to where it might cause damage to the point of developing cancer. So we don't know those risks yet, but there are other, obviously significant health risks with vaping in particular, where, we just, it's not safe. And, while the overall percentage of patients in the US has decreased quite a bit to 15%, part of that reason, which I didn't bring up, is the rate of patients using e-cigarettes or vaping has gone up, to kind of fill that gap. Whether or not that's healthy or not is unclear. So it remains to be seen. But it's obviously not. There are significant risks with vaping, health risks.
All right, the next question is about imaging these things. So maybe I'll try and lump them together based on that type of thing. So the first question that we got about imaging is there any way to confuse lung cancer and sarcoidosis when you're just looking at imaging studies?
Yeah, so we see all sorts of small spots, or abnormalities on the CAT scan when we're doing these, when anyone gets a CAT scan. And so the challenge is, of course, determining, what is cancer and what is just, scar tissue, or sarcoidosis is a type of lung disease. And sometimes it can be very difficult. Sometimes these spots in the lung can be very small, and it can be difficult to distinguish. I mean, that's why something, a biomarker or a blood test, there are a few out there on the market commercially, but a lot of research is being, done to try to, help us determine which spots that we see on the CAT scan are cancerous and which are not.
Right. Talking more about scanning, there's a question, can an MRI detect lung tumors?
Yeah, an MRI can detect lung tumors, but in general, MRIs are more expensive, and they're not quite as accurate as CAT scans in terms of finding lung cancer. So MRIs are good for other parts of the body, but not quite as much in the lungs. So we don't really use MRIs when we're dealing with lung cancer.
All right. What do you think are some of the reasons that people get diagnosed with lung cancer so late? And then their part B, what can we do to have earlier intervention in these types of cancers?
Yeah, so unfortunately, lung cancer, the reason why it's discovered so late is because it doesn't cause any symptoms until it gets really large, or until it's actually spreading to other parts of your body. It just doesn't take up a lot of space in the chest cavity to cause like shortness of breath or chest pain or anything like that. So that's why we just don't detect it until people don't really feel poorly either, until it's really spread quite significantly and causing a lot of problems. So the second portion of that question, Kate, was what exactly?
What do you think we can do to get some earlier intervention in these lung cancers?
Yeah, so the biggest thing is once again early detection, and the main thing that came out 10 years ago is for everyone that has a heavy smoking history is to get an annual CAT scan. So screening, lung cancer screening, just like mammograms, just like colonoscopies. Everyone with a significant smoking history should get a CAT scan every year.
Okay, so do you think that there should be recommended screenings for everybody, or just for people that have that heavy history of smoking?
Yeah, great question. So in general, if we screened everyone, in the U.S. population with a CAT scan, we would find too many, spots, that aren't cancerous, and as a result, patients, might need to get, unnecessary further tests or biopsies. So you just have to screen patients who are most likely to get lung cancer, because once again, almost 80 to 90% of patients that get lung cancer have a heavy smoking history.
All right. There are a couple of questions about the exposure to radiation via the CT scans. Can that lead to cancer, whether it's lung cancer or other kinds of cancer?
Yeah, great question. Get asked this a lot. In general, so it's a low dose CAT scan. So it's the radiation dose with the screening CAT scan is lower than even a regular CAT scan. And in general, the radiation dose is very, very low. You would need to get, many, probably thousands of CAT scans to get any sort of significant cancer risk. So it is totally safe to get a CAT scan every year.
Awesome. All right, let's move to some treatment things, because the prevention part is making me depressed. Is there a most effective treatment for lung cancer?
The most effective treatment for lung cancer is to do surgery if we can find lung cancer when it's smallest. I mean, that's when the prognosis is the best. Some of the newer medications that came out, like I said, some of the targeted medications in general have shown really high efficacy rates of getting rid of lung cancer. But there's still, the best option is to detect lung cancer early at an early stage and to do surgery to cut it out. That is your best chance of beating it.
Now, are patients asleep for these operations that you're talking about?
Oh yes, they are definitely asleep. It is a major operation. So although to be honest, there are a few case reports of surgeons doing big lung cancer operations on patients who are partially awake. But in general,
Mm.
everyone is completely asleep during surgery.
All right. New question. You mentioned robotics assisted 2-day average in hospital post-surgical recovery. What was the average before robotics came on the scene?
Yeah, when we had to do open operations, the average hospital stay was about 5 to 7 days. And there were all sorts of complications that happened afterwards. People had there was a lot of pneumonia, there was a lot of heart problems that happened. And all those problems kind of went away once we could do everything laparoscopically. It turned it from a major operation to somewhere between a minor to moderate operation.
And then what kind of risks or complications are there with the laparoscopic surgeries that are different from a surgery that you're not using a robot for?
Um, There really aren't a lot. I mean, it's really reduced all complications. There aren't any sort of unique complications when we're doing it robotically that we don't see when we're doing it like a traditional sort of open operation. So, um, yeah, basically it has reduced all complications.
Awesome. How do you ensure that the robotic instruments are sterile? It's a really good
Oh yeah,
question.
I mean, yeah. So the instrumentation goes through a sterilization process. There's a lot of safeguards to make sure that our instruments are sterile at the time of surgery. Unfortunately, to some degree, a lot of the instruments are replaceable. They have to be replaced sometimes during every operation, or maybe after 5 operations. So yeah, sterility is obviously a big deal. The infection risk after a major operation is very low, probably just a few percent chance of developing a major infection.
Well, that's good. Um, is there any kind of tumor size limit to the CyberKnife treatment you were talking about?
Yeah, that's a great question. In general, if the CyberKnife becomes less effective as the tumor gets larger, and sort of a rough cutoff that we use is about 5 centimeters. We can do cyberknife on anything, but yeah, the efficacy goes down as it gets larger.
Okay. Um, is there any data or thoughts you can give towards if you give immunotherapy for stage 1 cancer, will that enable you to fight it more effectively?
Yeah, that's a great question. There are clinical trials that try to answer this question. In general, for stage 1 lung cancer, the survival rates are quite good with just doing surgery alone. But we're always kind of tweaking it just to see, how can we improve those, survival rates without, subjecting a lot of patients to kind of unnecessary, side effects, or other treatments. I mean, even though the immunotherapy and the targeted medications have a lot less side effects than chemotherapy, they still have side effects.
Sure. And how effective is the CyberKnife versus surgery with, stage 1 or stage 2 cancer?
Yeah, great question. So in general, the gold standard for treating lung cancer is to do surgery when we can. But in patients who, there's obviously patients who have significant lung disease or, emphysema that, can't undergo surgery. And in those patients, CyberKnife is a great, choice.
So we have a couple of questions now about secondhand smoke with regards to non-traditional smoke. So for example, cooking fire or air fresheners or incense in church. Do you have any data on that?
There's no data, and other sorts of chemical exposures or more significant sort of exposures like that. In general, the risk is probably relatively low. Cigarettes are when people are smoking a pack a day, that's a lot of cigarette smoke.
Yeah, yeah. So you would constitute a pack a day as saying that would be heavy smoking? What's your definition of heavy smoking?
Yeah, a pack a day is heavy smoking. I mean, everyone should try to quit smoking, and no amount is safe, but an average, most patients are smoking about a pack a day.
All right. All right, let's is the survival rate with lung cancer any different if it depending on the area of the lung that the cancer is located in, like upper lobe versus lower lobe?
That's an interesting question. The answer is no. We don't really. The staging system that we use doesn't um, differentiate between upper lobe cancers versus lower lobe cancers. More cancers tend to form in the upper lobes because that's kind of where the cigarette smoke tends to rise to, in patients. But that's not associated with a worse or better prognosis. But that's an interesting question.
Yeah, I like that question. We got a couple of questions about PET scans, so I'm going to kind of smush them together. So first is, what kind of information can you obtain from a PET scan? And the second is, how do you figure out which is cancer in the PET scan? The person asking said the brain was all lit up as well as a small spot. So how do you know which one is cancer?
Yeah, so that's a great question. So a PET scan is, so I didn't go into it in detail, but for a PET scan, it's like a CAT scan, but they inject sugar into your body, and the sugar goes to parts of the body that are rapidly growing and use a lot of sugar. So cancer cells are rapidly growing cells, and they use a lot of sugar to grow abnormally. So they'll take up sugar, and you can see this on the PET scan. But other things also take up sugar on the PET scan. Like if you had an infection in your lung, like pneumonia, the body uses a lot of sugar to kind of fight off the pneumonia, and so pneumonia will be positive on the PET scan. So yeah, the problem with PET scans is it's not a PET scan can't 100% tell you whether or not something is cancerous. That's why you have to do a biopsy. Like I said with the robotic bronchoscope, you actually have to get a tissue sample to confirm that something is cancerous.
Okay. Is lung cancer resulting from smoking more aggressive than cancers you could get due to, for example, radon exposure?
That is also a good question.
They come up with good ones, I'm telling you.
Those are good questions. I don't think I've seen anything, any data related to that. There are. So the answer is I don't know, and I don't think so, but I don't know.
Okay, that's okay. We're allowed to not know, right? Let's talk about your work day, right? So what does your typical day or week look like?
Yeah, so it's a great question. So I do operations 2.5 days out of the week. And then 2 days I'm seeing patients in my office. And then a half day I'm doing kind of smaller sort of procedures like using the robotic bronchoscope. Most days, I'm in the office by about 7 or 8 and, done by 4 or 5. But the schedule kind of varies day to day. Obviously, on operating days, I can be in the operating room, later and get out later in the day. And then, unfortunately, like a lot of specialties, there's a lot of, what we call call, which we're on call for any sort of like emergencies or, issues, that happen with our patients. And so I may need to go to the hospital, maybe, a few times a month on the weekends, to see patients and take care of any issues. So that's kind of an average, kind of work day.
Sure. Let's see. How long do the operations take?
In general, about 2 hours or less. I try to if I can do it under an hour, I'm pretty happy. So anywhere between an hour and 2.
All right. So there's a couple questions about lung transplants. The first one says, why can't we use a lung transplant method for those diagnosed with lung cancer? And then there's a second question that says, if you do a lung transplant, can the cancer come back?
Yeah, so great question. While we do transplants in certain types of other cancers, like liver cancer, in general, we don't do transplants when a patient has cancer, primarily because the medications that you need to be on, the medications that suppress your immune system after you get a transplant can cause the cancer to kind of grow like out of control because there's no checks on the immune system to fight off the cancer. So so we don't. So that's the main reason why we don't do it.
Okay, so the permanent staples that you were talking about, what are they made of?
They're usually made out of titanium, but they don't go off in like airport scanners, and you don't feel them. They don't cause any problems. Yeah, I get it. Get asked that a lot.
Um, so there's a question about gender differences in lung cancer diagnosis. Do you know of any reason why men might be diagnosed more often than women?
Yeah, there's a good reason. That's because they smoke a lot more in general. That's what that. Let me just see this curve right here. So this is lung cancer related deaths in males. This red line, and then this green line is lung cancer related deaths in women. And the reason why these curves are a little bit different is because women started to take up smoking a little bit later than men. So that's why this curve is a little bit delayed.
What got you interested in this field?
Yeah, so good question. Growing up, I kind of always knew I wanted to be a doctor, and always knew I kind of wanted to be a surgeon. I was kind of always interested in heart surgery, and part of heart surgery, heart surgery training is also doing lung cancer surgery. And I really liked kind of dealing with lung cancer patients, and rather than heart patients with heart problems. I like kind of the longitudinal or kind of duration of care with these patients. So that's kind of why I switched this specialty.
Um, there's so many good questions on here. If somebody is interested in your field and would like to shadow you, is there a way that they can go about doing that?
Yeah, I mean, we have there are programs that exist through the Cancer Center. That's probably the best place to start out with. We do have college students that shadow us on a regular basis. It is a little bit difficult for high school students to shadow us, but it can be done. But if you contact the Cancer Center, we can see if we can try to arrange something.
Let's talk about CRISPR. Do you foresee CRISPR being used to develop like specific anti-cancer drugs, or being used as like figuring out a cancer vaccine?
Oh, that is a very interesting question. So, CRISPR, if people don't know, is a genetic tool that was developed that you can basically change the DNA structure of almost anything that you want, and you can change it very precisely. So there are actually researchers here at the Cancer Center. Dr. Kamesh, is the leading CRISPR scientist, has made significant progress in using CRISPR to fight off cancer, and specifically lung cancer. He's actually developing a drug or a treatment that uses CRISPR he's hoping to um, um, break the cancer pathways, specifically in lung cancer. So the answer is yes.
As you are recovering after surgery, because it is the lung, does the patient need more oxygen, less oxygen? How do you handle that?
Yeah, so the lungs are a little bit traumatized just from the stress of surgery and having undergone an operation. So, patients may need to use, extra oxygen just maybe for a day or two. Sometimes patients will go home, with extra oxygen just for a few weeks until their lungs kind of completely recover, although that's not common. When we do surgery on the lung, when we're cutting out a part of the lung doesn't grow back or anything like that. So we have to be careful in terms of who do surgery on, and most patients, the portion of the lung that we're taking out isn't really affecting their overall lung capacity significantly. So most patients recover just fine, and they can resume regular activities with any sort of issues really after just a few weeks. So
What is the longest operation you've ever had to do for cancer surgery?
um, Well, the longest cancer operations, our esophageal cancer operations can sometimes take 4 to 5 hours routinely. The longest operations I've ever had to do is when I was a fellow, I had to do heart transplant operations. And there was a heart transplant operation that lasted about 30 hours, where I was in the hospital for 30 hours and, kind of in and out of the operating room for 30 hours. So that was an experience that was tough.
I imagine. Speaking of tough things, how do you cope with the loss of patients due to the high mortality rate of lung cancer?
Yeah, so that's a great question. Obviously, it's very difficult. Um, we help patients as much as we can, but lung cancer is an aggressive cancer, and it can come back. Even with our best efforts. There's a lot of resources here at the Cancer Center. That's why when we have these multidisciplinary clinics, we not only have physicians, but we also have social workers, cancer psychologists, palliative care specialists. They help patients throughout this entire process. Even if the cancer were to come back, unfortunately, we can help them through this process. So we try to help patients as best as we can.
The robotic surgeries, if you have an allergy to some kind of metal, is that going to be a detriment to you being able to have a robotic surgery?
That's a good question. That issue has never come up quite yet. So, if someone had an allergy, we would have to discuss it, and I'd have to see if the robot had certain sort of components. But a lot of the metal components of the robot, and like I said, the stapler, are specifically like hypoallergenic. The titanium. Most of the robot instruments, I'm sure, are probably stainless steel. So that question hasn't really come up.
Okay. There are a couple questions about increased risk of lung cancer in people with asthma, specifically people with asthma who are inhaling albuterol through inhalers, and people with asthma who are inhaling secondhand smoke. Do you know of anything about risk factors like that?
Yeah, I'm not familiar with any of those risk factors. So in general, I would say that risk is relatively low compared to, once again, most patients who have lung cancer are heavy smokers. So at most it'd be a very low risk, if at all, but I don't know the data.
And you said that your, high risk is a pack of high people who smoke a lot. Yes.
Yeah, pack a day for 20 years is kind of a good sort of, cutoff.
Are there anything that would lower that standard to allow somebody to get the screening if they weren't that high, if they were like 15 pack per year or something like that?
So insurance companies, so the guidelines are, anyone between the ages of 50 to 80, and you have to have a 20 pack year smoking history. So that means like having smoked a pack a day for 20 years or 2 packs a day for 10 years. That would be a 20 pack year smoking history. So if you don't fit these criteria, unfortunately, insurance companies won't reimburse you for a low dose CAT scan at this point.
Okay.
Even if there was an established family history of lung cancer.
Yeah, that's not part of the criteria, unfortunately.
Wow. Thanks.
What are some possible reasons for lung cancer in non-smokers?
Good question. So oftentimes we'll find what we call a genetic mutation. Some of these mutations that we can target with some of the newer oral let me see right here. So these are common mutations that we see, and these mutations tend to occur more frequently in non-smokers. And in terms of why people develop these mutations and develop cancer, it's kind of unknown. At this point, it's kind of bad luck. If you don't have a history, heavy smoking or radon exposure, cancer can happen spontaneously, sporadically, in patients when you develop an alteration like this.
I don't know if you know the answer to this question, but I'll give it a shot. If people are looking for a quote unquote cure to lung cancer, what types of things are they looking for?
So that's kind of a
Not to put
broad
you on the
sort
spot or anything. What would you like to
of,
see in a cure? How about
right.
that?
I mean, this slide right here, right? How do we actually cure how do we cure cancer? Is there some sort of magic drug? Those we don't have a magic drug. Even those newer medications, the immunotherapy targeted drugs, are not magical. They're not going to cure everyone of lung cancer. I think this slide kind of illustrated kind of the best sort of points in terms of where we can really make improvements, and these improvements are gradual. They're not going to make it 100%, but these things down here are kind of what we have currently to try to reduce lung cancer.
Okay, here's a really good question. If patients are still breathing, either on their own or via ventilator when intubated, how can a surgical procedure or radiation treatment be done with pinpoint accuracy if the lungs are constantly expanding and contraction? Isn't this like trying to hit a constantly moving target?
So when we do lung cancer surgery, robotic surgery, the lung is deflated. So people ask me this all the time, and I guess I don't really think about it because it's relatively common for me. But when the anesthesiologist puts a breathing tube in to put you to sleep, they are going to just inflate the side that we're not operating on. So if the cancer is on the right side, the right lung will be collapsed, so I can operate on it, and then the left lung, the patient will be breathing with their left lung. And then when we're done with surgery, when I cut out the cancer in the right lung, we just inflate the right lung, and it's fine. In terms of the radiation, there's the CyberKnife machine actually will track the cancer as they're giving the radiation with the patient's breath, with the breathing. So when you go into the radiation department, they put you in front of this special radiation device, and it's moving basically in syncing with your breathing to make sure that the radiation is accurate.
That's awesome. If you're a patient and you have calcifications or granulomas on a CT, I assume you intermittently recheck this. How often do you recheck their CT to make sure that those haven't, gotten worse?
Yeah, so great question. So there are guidelines in terms of how often we get CAT scans for spots that we see on the lung. These are guidelines given by the radiology sort of societies. They're called the Fleischner guidelines. Mostly it depends on the size of the lesion. If something is like a centimeter, for instance, we might follow it more closely with a CAT scan every 3 months. If something is smaller, like half a centimeter, we might be following it every 6 to 12 months with a CAT scan.
Sure. And if you do have, let's say, pre-existing interstitial lung disease or sarcoidosis, does that lead to more likely to have cancer?
So this is a question. Yeah, I don't know the exact answer. In general, the risk of developing, it's relatively low if you have sarcoidosis, or I'm not sure what the data is in terms of what is your risk of developing cancer if you have sarcoidosis versus someone that doesn't have sarcoidosis who's otherwise has healthy lungs. I don't think it's different, but don't quote me on that.
All right, we won't record that part of your answer. What are common symptoms of lung cancer?
Yeah, so unfortunately, as I mentioned before, lung cancer doesn't cause a lot of symptoms until it's really large, or until it's caused like a lot of damage in your lungs, or until it's like spread to some other parts of your body. So it can get very large before it causes like shortness of breath, chest pain, coughing up blood. Those are kind of the late findings of lung cancer, unfortunately. A lot of patients with lung cancer are totally fine. They feel well. A lot of people are surprised, unfortunately, when they find out that they have lung cancer.
Yeah. Do lung cancer do lung cancer surgeries result in a lot of blood loss? And does using robots for the surgeries prevent blood loss? Does it prevent, errors? Is it more or less common in a robotic surgery to have errors than in a non-robotic surgery?
Yeah, great question. So in general, because of robotics, we can do operations more precisely and with less blood loss. It is very uncommon for us to have to transfuse patients with blood during any type of lung operation. In general, I can only remember maybe less than 5 times where we've had to give blood transfusions during a case. So it happens very infrequently. And in general, there's very minimal blood loss. I would say, I'm not sure milliliters, but maybe 50 milliliters or less. I don't know what it is in ounces, but maybe an ounce or something. Like it's not significant. It's very little blood loss.
Let's see.
Hey, can I
Yep.
slip a question in real quick? So with a 20-pack, what was it, 20-pack a week? I was going to say 20-pack a day. Whew, boy. Anyway, whatever
That's a lot.
whatever that average number was that is insurance acceptable. I think the question is, why, in your experience, would somebody not jump at the opportunity to go in and get scanned? What kind of psychological barriers would there be? And what my brain automatically jumps to is figuring there's something wrong and simply not wanting to know it. But can you talk a little bit about that?
Yeah, I'll start out with saying that, this is a relatively new sort of guideline, so it's only been out for about 10 years. The adoption of this is still really poor. I mean, right now, only about 10% of all, patients who could be screened with an annual, CAT scan are actually screened. So it's just, I think patients don't know about it, providers, physicians don't know about it. So it's something that we're constantly trying to promote and either through any which way we can. But I'm not sure. Obviously, there's a fear, in trying to, of knowing whether or not you have cancer, and maybe that causes patients to not wish to, have a CAT scan. I think someone mentioned as well, they were worried about the risks of radiation with annual CAT scans, so that might be a factor. In general, I think a lot of it is just not being familiar with these recommendations. It's a really simple test. It's very safe, and it will catch lung cancers at an earlier stage where we can do more for patients.
You want to keep going, Tim, or are you passing it back to me?
No. I just wanted to stick that in there sidewise. I was having a little sidebar with somebody in the Q&A.
All right, so there's a couple questions that are similar to this, so I'm going to ask one question. Are there specific areas or pockets of residents in any cities or areas within the state of Delaware with higher cancer rates? And if so, do we know why those cluster locations are affected? For example, is there a high percentage of Delaware City refinery employees diagnosed with lung cancer?
So that's a very interesting question. So one of our scientists, Dr. Scott Siegel, is specifically looks at the geographical sort of risk factors for developing cancer. He's done a lot of work with breast cancer, and for instance, there's a link between alcohol use and developing breast cancer. So pockets of the state that have higher alcohol abuse tend to have higher breast cancer. And we are trying to do these same sort of studies to figure out if there's a link between, whether or not you live in, more heavily polluted areas, or, some type of, is your risk of cancer related to where you live. So the answer is we don't know, but there's research being done to try to figure it out.
There's a question here. When you are doing surgery, do you take a frozen section to check the margins and make sure they are clear prior to finishing the surgery?
Not always. It really depends on the situation. You know, if I'm pretty confident that the margins are going to be fine, then I don't. But if I'm concerned, then we do.
Okay.
So just case to case, case by
Okay.
case.
We hear about non-small cell cancer and other types of cancer. Are there better survival rates with some types versus others?
Yeah. So when we're talking about lung cancer, the vast majority of lung cancers are what we call non-small cell lung cancer. There's a more aggressive type of lung cancer called small cell that's treated a little bit differently that I didn't really, you know, delve into too much with into this talk. But yes, there are more aggressive and more slower types of lung cancer. There's a wide spectrum.
All right, this question is asking about a connection between COPD and lung cancer in someone who was once a long-term smoker. Are they at a higher risk?
I'm sorry, can you repeat that, Kate? What was the question?
So the question is asking, is there a connection between COPD and lung cancer in someone who was once a long-term smoker? Are they at a higher risk?
So I think the question would be better rephrased. So COPD or emphysema is usually related to heavy smoking. And so that's a side effect or, you know, from consequence of smoking, usually, not always, but usually. And as a result, you know, is a risk for lung cancer. You know, your risk of developing cancer, you know, goes up with how much you smoke, and it goes down once you quit smoking, but it doesn't, you know, go down to the point of, you know, someone who's never smoked.
Here's a fun question I'm sure Tim will like. Do you think AI will eventually replace operating room doctors?
Yeah, so I mean, I brought up that you know, picture of a robot.
Are you looking at questions?
I'm sorry.
What, Tim?
So yeah, once again, I mean, there's a robot that they developed at Hopkins that can do surgeries on it, you know, small operations on its own. Is that ever going to become prime time? Hopefully not for my sake, but we'll see.
Let's see. Lungs are usually responsible for the delivery of fresh oxygen, helps with the circulation of blood in our body. Does anything happen to the circulation of blood when the patient is diagnosed with lung cancer? Does the, you know, tumor affect the circulatory system at all?
That's an interesting question. In general, most lung cancers are relatively small compared to the volume of the lung. So while lung cancers, so in general, the answer is no, most likely. I mean, cancers in general tend to, you know, kind of suck up more blood, and they need more of a blood supply than other parts of the, you know, normal parts of the body. But it's usually lung cancers are not, you know, big enough to cause significant problems. So we don't really think of it, you know, in those sorts of terms.
That's very good to hear. If somebody had a different kind of cancer, in this case, the example was given bladder cancer, and then they had a successful surgery with removal, they had chemo, they had radiation, is it possible for them to get lung cancer without it being a metastasis of bladder cancer? Like a brand new cancer?
Sure, absolutely. Some patients have, you know, multiple different kinds of cancers. You know, bladder cancer is, you know, a risk factor for developing bladder cancer is smoking. You know, kind of smoking is a cause for multiple types of cancers, and so yes, we see, you know, patients with who have had kidney cancer, and then they develop bladder cancer, and then they can develop, you know, lung cancer. So that happens.
Yeah. Can you talk about glass lung? Is it a type of lung cancer? Is it a precursor to lung cancer?
Yeah, so I think what they're mentioning here is on CAT scans, there's a type of spot that looks like a smudge on a window pane, kind of what we call a ground glass sort of lesion. And these spots on the CAT scan are especially difficult to determine whether or not they represent cancer or whether or not they would just represent some scar tissue in the lung. So yeah, that's, I think, what that question is referring to. So did I answer that, Kate?
Yeah, I mean, I got it. All right. Last question. We got there. Oh, maybe not.
I have one.
All right. We're going to do 3 more questions. That's it. Is there a certain type of patient you would treat with immunotherapy as opposed to radiation?
So there are, so it really depends on the patient's stage in terms of what we recommend. Immunotherapy is a type of medication that goes throughout your body. So if the cancer was, we use it in all sorts of instances but especially once, in more advanced stages, we tend to use immunotherapy more. Radiation is very focused treatment. So if we know the cancer is just located in one spot, then we can do radiation. We can't radiate the entire body. So radiation has very specific sort of indications.
Do any congenital heart diseases have a higher incidence of lung cancer?
Not that I know of.
Okay. There's a really, really specific question in the chat that I'm going to let you answer because it's really, really specific. So Tim, why don't you ask your question?
All right. So if there were going to be a non-person person of the year this year, I think it would be AI. And you may have spoken to this. I was furiously answering questions myself, so you may have addressed this, but at the Helen F. Graham Cancer Center, or more broadly, how much is AI entering into the query against huge data sets and or working in tandem with the robotics and, from a detection and elimination standpoint?
Yeah, so I mean, AI is kind of the biggest, buzzword that has come about over the past, few years. Its applications in, medicine are very, there's so many different types of ways that AI is being used that I can't speak to all those ways. So, for instance, in surgery, we're using, obviously the biggest part of AI would be to try to develop like an autonomous robot or something that can, do parts of the operation on its own. But there's other forms of AI technology that we're using in surgery that can help us specifically during surgery. There's AI programs that can, give a three-dimensional map of the lungs that we can use in real time, as we're operating. So that's an AI sort of tool. There's AI, I mentioned here in terms of, helping us look at CAT scans to determine which spots are cancerous or not. There's a lot of AI in terms of analyzing health records, to try to synthesize, a lot of, health records to give more, focused information. There's just there are a lot of, it's a very broad, AI can be applied very broadly in very different ways in medicine. So it's not one specific thing where it's being used. It's just kind of starting to creep in. It's not something, that's taking over. There's no WebMD AI doctor yet that can you can ask questions to that can tell you what kind of disease you have or what the treatment even will be. That would be an AI sort of thing.
Right. One of the questions which I answered was somebody asked whether the Helen F. Graham Cancer Center had a quantum computer yet. And just to enlighten everyone, the answer to that is no. And in fact, really, no one at this point has a quantum computer that is reliable enough in a broad range of applications to go into production. That's still a ways down the road. Quantum computing is really a separate issue from AI, even though AI takes a lot of processor capacity. It's not at the same level as quantum. So we'll talk about that in 10 years. Doctor, thank you very, very much. It was a fantastic presentation. It looks to me like you fielded about 150 some odd questions. That's fantastic.
Yeah.
Folks,
Wow.
next week, We're going to be learning about behavioral health, understanding addiction and anxiety and depression from Vishesh Agarwal and Matthew Lind. We'll see you all next time. And remember, the recordings and presentations will be at delawareminimed.org. Have a great night. Good night.
Thank you.